was walking through the biotemps department the other day, and I noticed a case that I thought was an interesting one and a really kind of novel approach to an interesting problem, and I wanted to share it with you because I'm not sure that you've had a chance to see this. And this is a pretty typical issue that we see. We've got two anterior implants that have been placed here, and they're of course healing, and we've got some healing caps here. So these, the bone here, I guess, was not good enough to go with any kind of immediate load here. And so we've got a couple of options here for what the patient's going to wear over this. We have a stay plate, something removable that would cover a lot of the palate so that the patient could have two teeth sitting over this. Probably have a couple of clasps, maybe in the posterior around the second molars, for example, to replace these two teeth, but would cover a lot of the palate. Not a super comfortable thing for the patient to wear. If it was just for cosmetics, perhaps one of our smile transition products, kind of like a snap-on smile that would cover some other teeth, if the other teeth really had some aesthetic challenges on their own, which they don't have here. So that might be a little too much for a case like this. You could possibly also go with something like a small partial. That might be kind of expensive though. Put a couple clasps on the facial and the lingual of the central and the cuspid here. And really, you know, you've got your choice of a couple so different ways to give the patient a way to kind of cover these up and have something to be able to go to work, maybe, you know, go out to dinner. It'd be nice if they could eat with it in, perhaps, and just something while these implants are integrating. And so they can really just kind of function in life and not have to cover their mouth when they smile. And so as I walk through the biotemps department, one of the things that you'll see, of course, would be a biotemp bridge, for example. If, you know, I guess if these two teeth were going to be prepared for single unit crowns later next to these two crowns, or if this had been a bridge before and the bridge came off, the bridge was removed, this 4-unit bridge, and now 2 implants were going here, and these were going to be single unit crowns. This, of course, could be a biotemp bridge from here to here over those 2 implants while they integrated. And that would be fine. That would look nice because we'd have some hollowed out denture teeth, the biotemp facings, with our 2 ponics here, and that would look very nice. But these 2 teeth are virgin teeth, and these were just missing while the patient had a stay plate before, or whatever they had in place. I actually don't even know, just walked through and saw this case. I guess if the patient did have a stay plate, then they would probably be used to it and you could do it, but they didn't have a stay plate, and so I'm guessing the patient did not have a pre-existing stay plate. Maybe this was a traumatic injury that caused the loss of these teeth. And so what I saw was an interesting biotemp. It's not one that's going to be a full coverage one on both of these teeth. It's basically going to be a biotemp Maryland bridge. And so it's going to look a lot like a regular biotemp does. It's going to be highly aesthetic. So it's going to have the hollowed out denture teeth that we typically see, which is why biotemps tend to be so aesthetic, because they have the nice incisal edge translucency, and they've got the nice gradation between the incisal third, the middle third, and the gingival third. And then they're backfilled with the acrylic. You can see here, as opposed to, say, a typical biotemp, that they've been countersunk a little bit to leave some room for the healing caps. And you can see the 2 wings. And typically, as with most biotemps, there's a wire in the back so that even if there is a small amount of cracking, we can maintain some integrity of the unit by having this wire in the back. I have a case like this where we have a patient where we removed a bridge and we're going to place a single tooth implant. And I had the biotemp made with mesh in the back rather than the wire, so that when I sent the patient for the cone beam, we didn't have to remove the biotemp because we weren't going to get any scatter from the mesh that was in there, almost like a ribond type mesh to reinforce what was in there. The scatter that you'll get from metal like this on a cone beam scan or a metal on a PFM bridge will cause issues. And so when a biotemp's being made and the patient's going to have a cone beam scan with it in place, we will go with a mesh instead of the wire. But that's not the case on this case, because the implants are already in place with the healing cap. So a wire is the preferred way for reinforcement on these. So again, it's countersunk to sit over that. And so what the dentist would do in a case like this is just go ahead and spot etch on the lingual of both of these teeth, because again, this is not going to be something removable per se. This is going to be something semi-permanent, well, or fixed removable, if you will. And you can see, you can even make a mark on the teeth if you want, or just memorize where those wings go, and then just spot etch with some phosphoric acid on both of these teeth for about 15 seconds on the enamel. Rinse it off. Depending on how strong of a bond you want, then you can place some bonding agent here. Obviously, we wouldn't necessarily need any dentin bonding agent. I would just use like the dark green bottle from the Scotch Bond system. The adhesive, if you will, from the old 2-bottle systems without the primer. And use some adhesive here, air thin it, and then place a little resin cement either directly on here or on the wings itself. You could also place some of that adhesive resin, the unfilled resin, on the wings here as well, and then air thin it, and then put some of the resin here. And then I would put this BioTemp Maryland bridge down into place onto the patient's teeth, and with your thumb put a little pressure on the 2 pontics towards the facial to make sure it's seating all the way. And my assistant would come in and take a micro brush and just clean very quickly on both of these, and then cure it from the lingual on both of these, and maybe from the facial for a little bit as well. And then we could go in with a football burr, like a 7408 burr, and then clean and smooth up this margin here. And so it would be kind of spot welded, if you will, in place where we went in and did our spot etching underneath these 2 wings. Depending on the patient's occlusion, we may or may not have to adjust the bite or recontour those lower incisal edges here. It looks like here we're okay, and we are in contact on those posterior teeth, and it looks like we have just a little bit of space there on that cuspid and maybe on that central incisor as well. So I don't think any adjustments need to be made there, but if it did, I'd get a coarse soft flex disc out and do a little disking on those lower teeth. But you can see that for a patient, this is a pretty darn good option to have this sitting on top of there while those implants are integrating, to have something that's going to stay in place. It's bonded into place. It's not a superhuman bond that we have there. We just have a little circle of phosphoric acid that we use to etch it into place, and then the rest of that wing is really just kind of held in place by the composite being bonded between the 2. It's not a metal wing like on a typical Maryland bridge, and so we are going to instruct the patient, hey, be careful. It's summertime, corn on the cob, apples, things like that. We're not going to want to bite into it with these teeth because we might torque it and be able to pop that off. Anything you can eat with a fork, you're going to be fine eating because you'll be chewing it with your back teeth. But that is a very highly aesthetic way to temporize this while we wait for those to integrate, and before we finally put the abutments and the final crowns on those. And compared to a flipper and some of the other ways that we've traditionally seen to temporize an area like this, very aesthetic, very minimal, patient barely knows it's there, just a little additional thickness on the lingual of a couple of anterior teeth. And I think a very elegant way to treat a situation that usually had kind of a bulky and a not very aesthetic way of dealing with it with something like a flipper.